So staying on topic of robotic microsurgical vasectomy reversals, I was just going to update our experience from our center in Austin. So thank you guys very much for joining us for this discussion today. So obviously what we're talking about is the choice of using a microscope versus a robotics for microsurgery, and obviously I think a lot of us are of the same mindset here with these discussions. So in the United States, there's about 500,000 vasectomies that are performed every year, and somewhere about 6% of those men within 10 years of their vasectomy change their mind and decide they want to have more children. So if you think 6% doesn't sound like very many, that's actually 30,000 men out of that group. So it's a lot of guys. With a greater than 50% divorce rate in the US, that tends to lend to a lot of vasectomy reversals. So the first microsurgical vasectomy reversal was performed in the early 1970s using microsurgical techniques, and that really improved the outcomes. Because depending on the portion of the vas deferens, whether we're working on the straight, where we all like to do the repairs, versus the more challenging ones in the convoluted vas deferens, we're talking about somewhere between a 0.7 and a 0.4 millimeter lumen. And then when we go to vasoeptidymostomies, we're talking about a tenth that size of that lumen. So very high levels of microsurgery. The factors that impact our outcomes, number one is quite frankly, how good are we at them as surgeons? As surgeons, our level of training and experience, and I would echo what Dr. Devocard and what Dr. Selber have already said, which microsurgical training and tissue handling and minimal touch techniques are crucial. So we want to make sure that we're, especially with the advent of robotic microsurgery and the progression of it, that we're giving it a fair chance and not having poor outcomes by surgeons that maybe don't do as much microsurgery, just jumping on a robot and trying it, because the technique should be the same as a microsurgical technique, just using this advanced tool. The appearance of the fluid and whether there's sperm in the basal fluid is also crucial to know where to make the anastomosis. So these are what we're talking about, of course, is the promise of robotics and microsurgery, which is why we're all here. And at present, the standard that we're using is the Da Vinci system, although obviously I think we're all pleased to know that there are competitors that are up and coming with hopefully more agile and lighter and less expensive devices. So we all know the components of the Da Vinci and historically how that's come about. So as far as vasectomy reversal, there have been a number of publications now in robot-assisted vasectomy reversal. In 2004, there was the ex vivo robot-assisted vasovasostomy that showed elimination of tremor and comparable patency rates. Again, in 2004, there was a robot-assisted vasovasostomy and vasoeptidymostomy in a rat model, which again demonstrated improved stability and motion reduction during suturing. In 2005, there was a multi-layered robot-assisted vasovasostomy in a rabbit model, and then Dr. Pericotto published the first human study showing shorter operative times, higher mean sperm counts in his experience in 2010. I published a validation study in 2014 showing that I had equivalent operative times between my microsurgical and robot-assisted techniques. The patency rates, my raw numbers were higher in that series for my robot-assisted group, but they were not statistically significant difference. And we happened to have a mean time to pregnancy that was faster in our robotic group by about 4 months in these patients. So I think the concept of good isn't good enough, so we're all familiar with Steve Jobs pushing the envelopes as far as technology, and as our robotic industry tends to push that envelope, we need to be there alongside with them to make sure we're using it in a manner that's optimal for our patients and hopefully will improve outcomes and minimize costs. So some of the advantages of robotic microsurgery, I think most of us are familiar with these, but we're getting elimination of tremor, improved stability. The 7 degrees of freedom minimize the limitations of movement, make it a more fluid operation for us. Surgeon ergonomics, decrease surgeon fatigue. I think this one is crucial for me. If I do 3 to 4 micro cases in a day, my body's pretty beat up. I'm pretty worn out by the end of that day, where I can sit at the robot all day long and feel pretty fresh. Scalability of motion is obviously a very nice feature. The 3D high definition visualization, being able to manipulate 3 surgical instruments in a camera simultaneously and having complete control of that operation, I think is a crucial component. And there is a de-emphasis on specialty skilled microassistants. If you're working around a 1 millimeter artery, you're trying to preserve you don't want anybody else that isn't very well suited to be in that field fumbling around there. And in private practice, you don't always get the same assistant. So that makes it nice to give me the full control of that. Unchanged surgical field. If you're doing a higher level repair like a vasoepididymostomy and you get to a level of frustration, you can back out of that robotic console, take a breath, pop right back in, and nothing in your field has changed. Where at a microscopic setting, when you do that and come back in, you have to reset everything, reestablish your baseline again. An operative time, which there is a learning curve, which we'll discuss here. So I typically use the 9-0 suture that we were discussing. Nylon is typically what I would use. And this is just a demonstration in a simulation model of how limited we are in microsurgical movements in a very small space versus some of the advantages you get with a robotic microsurgical movements in that same limited space and the level of agility that gives you. And so in that same simulation type model, again, you can certainly get the job done. We've proven that for years, but it gives you some limited ability and not quite as fluid and meticulous of a nature. Where in our robotic microsurgical suturing simulation, you can see the fluidity of it, the stability of the field, and it makes it a lot more of an elegant procedure when you're using robotics to help you with microsurgical techniques. That's I think we've all seen that demonstrated, but it's just a very nice, elegant technique. So can you click the top left slide for me, please? So this is showing in the two screens here a visualization of a microsurgical vasectomy reversal vasovasostomy along with a robotic one. And if you just toggle your eyes back and forth, it really demonstrates, I think, the stability of the field and just, again, how elegant and precise you can be. Not that you can't be precise microsurgically, but the stability of that field, and it's really physically an awful lot less taxing when you're trying to anastomosis lumens of this size. So this is my technique on the robot-assisted vasovasostomies, and I try to use a mini incision to do this. So I use about a 1 centimeter incision here, which about 90% of my patients postoperatively tell me their experience and their recovery on their vasectomy reversal is very similar to their vasectomy experience, which is nice because traditionally a lot of people will deliver the testes. Nothing wrong with doing that, but you can actually do this through a pretty small incision and isolate your vasectomy defects the majority of the time, as long as they're not too low. Now, if we're doing a vasoepididymostomy, obviously we're talking about a different scenario where you're making a bigger incision, but you can see you can isolate both vasa, and this is division of the testicular end of the vas deferens. And I just full grade the side that I'm not using so it doesn't confuse me if things get lost. We take a little vasal fluid from the testicular end, make sure that we've isolated sperm, and that we know we're in the right place to make our anastomosis. And we divide the abdominal end of the vas deferens and inject saline through it to demonstrate patency, to make sure there's not a upstream or downstream, I suppose, obstruction that would make you have to go a little farther up to get your anastomosis. So you take a 25 gauge angio catheter and just inject saline through it. You know that there's no pressure back up there. You're in a good place. I use the microspike vasal approximator, the clamp, to get the ends back together here. And then really the portion I'm using the Da Vinci system for is the anastomosis, which I think is where it really gives me an advantage is with luminal anastomoses. I use a 1-layer modified technique, so I'm putting 12 sutures. These are 9-0 nylons transluminally, not 12 transluminally, I'm sorry, 6 transluminally, and then 6 in the seromuscular layers between those to give a tension-free anastomosis. And so this is 9-0, and I would echo what Dr. Debelcard already mentioned, which is, early on in my experience, I was breaking a ton of sutures, and then your brain feels like you learned that haptic feedback and that tactile feedback where we all know you can't feel it, but you feel like you can. I just snap my stitches here rather than cutting them with a fourth arm. That allows me to use one less instrument. And I've gone to doing that. That does help from a cost standpoint too. That's one less replaceable instrument that we're having to use. So hands together, pull apart. These are 9-0 sutures. They can come apart very easily. And so obviously in the interest of time, I'm not going to show tying down every one of these knots, but you get the idea of placing the transluminal sutures here. And then, so 3 go on this side, and then 3 will be placed in the seromuscular layers between those. And then the vas clamp is useful because your assistant at the bedside can just flip the clamp over for you, and now you can work on your posterior wall without much effort there. You can see that we try to leave the vasal adventitia intact, so you maintain microvasculature to the vas deferens, and that way it's going to minimize stricture rates. And these are the seromuscular layer stitches that are being placed here. And then we'll flip over the vas and anastomose the other side. And what I do in that manner is I'll place the transluminal sutures without tying them down. So once we flip, I'll pass the 3 transluminal ones, just leave them in place, not tie them down so you're able to see your lumen and you're not compromising your visualization with tying the anastomosis down. And then tie the 3 transluminal sutures, and then go ahead and put your adventitial ones, your seromuscular ones in after that. So that's as simple as that, and that's about as much as I need my assistant to do during this operation besides handing sutures. And then you're going to pass your transluminal sutures and et cetera. I think that's frozen up on me here. Can you advance the slide for me, please? So, again, I think this demonstrates how we try to really use a minimal touch technique, and you see we really don't try to touch the vas deferens, don't try to touch the lumen very much. And you're just manipulating the needle and the adventitia to get things approximated and get your anastomosis done in a way that's going to be tension-free. And so it's application of microsurgical principles, just using this different tool that's allowing us to have a little bit more of an elegant operation here. And then I've updated our outcomes, which hopefully we'll get up in a second, and we can talk a bit about the learning curve. My experience was that I was trained in my urology training at the time where we were transitioning from open surgery to robotic surgery. So really the Da Vinci started getting, and this just shows you how small you can make your incision for that reversal. So this is a 1 centimeter or less incision here. So this is the Gardner-Palmer tech height curve. And this is basically applicable to anything in technology, whether we're talking about robotic microsurgery, the Tesla, the iPhone, whatever. So there's a technology tremor, and then there's an increase in visibility of that technology. And then we always have a peak of inflated expectations. This technology can do everything, and it can do it better than anything that's ever been. And then there's the trough of disillusionment where we go, maybe it's not as great as we thought it was. There are some limitations. We have our slope of enlightenment and then our plateau of productivity. And I think we're heading onto our plateau of productivity as far as the robotic microsurgery platform goes. So as far as outcomes, hopefully we do a little better than this class here, where 99% of the sperm cells are being told that they will fail. But so this is my microsurgical versus robotic microsurgical experience, and these are patency rates, and they're based on time frame since vasectomy. So we break this down because the farther out you get from the vasectomy, the more increased pressure you get on the testicular end of a potential scarring of the lumen and increasing risk of having to do more complex anastomoses like vasoepididymostomies. So we break that down in a 0 to 8 year time frame, and when we compare the microsurgical versus robot assisted, there was 93 and 96% patency rates. In the 9 to 15 year mark, there were 94%, 97% of robot assisted. And it shows you the number of vasoepididymostomies that had to be performed during those time frames as well. Greater than 15 years tend to be the more challenging cases. They tend to require higher levels of complexity. We usually get a lot more convoluted vas deferens anastomoses when we're talking about vasos, and we're seeing more vasoepididymostomies. So in the microsurgical group, my patency rate was around 80%, and the robot assisted was around 77%. And then overall patency rate, regardless of time frame, were 92% and 95%. And so you see that none of these were statistically significant differences between these two groups, showing that we're achieving equivalent outcomes with robotic microsurgical techniques, and that's including the first series of cases that I did. That looking at those same series of those two groups, the sperm concentration 6 weeks postoperatively were fairly similar, 29 million per milliliter and 25 million per milliliter. And again, there was not a statistically significant difference between those two groups in my patient population. As far as time, I looked at mean operative times and I looked at mean anastomosis times, because the anastomosis is really where I'm using the robotic platform, so I wanted to see where did we see a variation there. In the operative times, my microsurgical technique was still faster at 110 minutes versus 119 minutes, and that did show statistical significance. However, clinically that means it's a 9-minute difference, so as far as cost and operative time, that's pretty minuscule still. As far as mean anastomosis times, they're very similar, 60 and 63 minutes with no significant difference between the two. So how about the learning curve? Is this a challenge for us? So I broke mine down into a set of 4, where I looked at my first 25 cases with the mean obstructive interval of 9 years, standard deviation of 6, and the range between the years of obstruction between 2 and 25 years, and there were 2 vasoepididymostomies in that group. On my 26th to 50th case, also had an obstructive interval mean of 9 years with standard deviation of 6. That range went between 3 and 29 years, and there were 2 VEs. In my third group cases, the 51 to 75, the obstructive interval was a bit less, 8 years, standard deviation of 4, and my range on those years was less as well, 1 to 15 years, and there were 2 VEs in that group as well. And then cases 76 to 94, haven't quite got to that 100 yet. The obstructive interval was 10 years with standard deviation of 5, with a range of 3 to 23 years with 2 VEs. So patency rates were very similar across the board, regardless of the number of cases or where I was in my experience, 96%, 92%, 92%, 95%. Operative time did decrease overall as the trend, 122 minutes, 121, 115, 118. There was not statistical significant difference between those. The anastomosis time tended to decrease as well, 75, 63, 56, and 57 minutes. And that did show statistical significant difference there. So we're seeing faster anastomosis time, which is where the robot is playing a role. And you can see the sperm concentrations there, not a statistically significant difference there. So what's next? Overcoming some of the challenges, improving microsurgical instrumentation for robotics, optimizing the platform, improving magnification, and decreasing pixelation. As we're evolving, again, we're starting with microsurgery, just using the naked eye with fairly poor outcomes, advancing to using loops with still moderate to mild to poor outcomes. The big advancement was going up to the operative microscope, where we saw massively improved outcomes, and now we're showing equivalence using robotics. Thank you very much.